Hello, Professor Zeller, can you hear us from Denver?
Hello, we can hear you clearly. Welcome and good morning.
Good morning to you. Good morning to you. We have a full room here, a fantastic panel. Let me first have you introduce your team, and then I can introduce the panel if that works better.
Yeah, I'm together here with one of the senior physicians, Dr. Jacques, who will assist me during the case. And outside we have our cath lab nurse, Eva. She will hand over the devices as needed.
Great. Here on the panel, I have Tony Doss, Stephen Hinoy, I have Alec Farber, Art Lee, Peter Sukas, Dr. Nizal, and Dr. Norman Cummings. So we have a full panel of experts from all specialties to ask questions and learn from this case.
Excellent. So let's briefly introduce you into what we prepared and what's our strategy for the upcoming 90 minutes. So it's hard to determine whether a case really lasts 90 minutes. So we have prepared two cases, two patients in two different labs. We will start here with this first case, and as soon as we are getting at the point where it's becoming a little bit boring because we have to inflate balloons for minutes, we will switch into the other cath lab, and this is what we are aiming for today. To give you insights into what's our daily practice as as much as possible. And the background of the session is CLI, and so I would like to briefly introduce into the patient. I have no patient files, but we are here together with an 81-year-old gentleman with chronic critical limb ischemia of both legs. On the left side, he was treated 1 year ago with a venous bypass graft from the proximal SFA going down to the peroneal artery. However, this bypass had already two failures needing interventional procedures. The last procedure was done in May here, improving the outflow into the distal peroneal artery, so drug-eluting stents had been placed there. Since that time, the wounds he was developing before the procedure on his left foot did heal in part, and the rest pain was released. And today we are going to treat the right leg. Here he developed a small pressure ulcer at toe level, and from the anatomical side it's known that there is a popliteal occlusion at least for 5 years. So what we can do first is to give you a brief introduction into the angiogram, and then we can discuss our strategy. So this is a bolus chase angiogram. You can see stenosis in the mid segment, in the distal segment of the SFA. Then there are two tight lesions in the proximal part of the popliteal artery. And then the artery is occluded at the level of the patella with originating two big genicular collaterals, and they are providing one below the knee vessel, which is the peroneal artery. And you may appreciate that in the proximal to mid part of the peroneal there's also a focal stenosis. And we can switch now to DSA to show it more clear how the outflow looks like. These are the collaterals, and what we see over here again, that's the peroneal artery. There's a faint filling of the TPT proximal to the peroneal artery, and if we go further down, foot perfusion is provided by collaterals to the anterior tibial, to the dorsalis pedis artery. So we have complete occlusions of the anterior tibial artery and posterior tibial artery as well as of the plantar artery, and we have one vessel runoff which is affected by this focal stenosis via the peroneal artery. So any comments and questions so
that's-
far regarding this case.
That's great, Thomas. It's a very interesting case, I guess. Why don't I have you get us started, and then I can ask the panel about the strategy that they would take. Tell us
Okay.
what you want to do, and then we can maybe discuss it with the
Good.
panel once they get started.
Okay, so our first step will be to perform the treatment of the inflow disease. This is due to two reasons. Number one, we need to improve or guarantee sufficient inflow during our recanalization process of the popliteal artery. And number two, in the, I hope, unlikely case of failed recanalization procedure of the popliteal, the improvement of the inflow will already provide better flow to the collateral and may already result in a benefit with regard to improved wound healing of the toe wound. So what we have prepared over here, this is the shockwave balloon. So we are going to perform lithotripsy because what you may see later on in the fluoroscopic image, the femoral popliteal artery is severely diseased, and that's for us a good indication for lithotripsy.
So while Thomas is getting his wire down and putting the lithotripsy, the shock wave down there, let me start with the panel. Peter, when you see this case, do you think it's sufficient to just treat the SFA and then see what happens, or do you believe that at least you should have the popliteal recanalization to have a one straight line flow, given that the patient has CLI? We didn't see the wound pictures. What are your thoughts?
Yeah, I think that ideally we would like to establish inline flow to the foot, given the fact that this in fact is a CLI case. I do very much like the idea of intravascular lithotripsy here. I think that given the extent of the calcification, if you can get a nice result with lithotripsy, either alone or followed by a DCB, that should be able to give you a very nice result, and hopefully even avoid the need potentially for putting stents in there. Obviously, with that impaired outflow, if you could get away with leaving nothing behind, that would be an ideal scenario. So, yeah, I think this is a great strategy.
Okay. Anybody else on the panel has experience with lithotripsy and shockwave?
Take him off here too.
The question I wanted to ask is that in this situation, obviously we have few collaterals, and there is sometimes embolization with all these technologies. And my question is that when you're doing these kind of cases, when you want to treat the proximal, you have an occlusion distally, and you have collaterals, is it better to open the distal first to have a runoff before you start throwing debris? What do you think, Tony, in this situation?
Well, I think actually Tomas picked a very reliable device that would reduce the embolization. Because remember, the way the shockwave works, obviously, is that the bubbles that are created inside the ultrasound, it cracks the plaque from the insides of the intimal and adventitial layers, and embolization is actually less of a risk than if you're taking something that's shaving the plaque off from the intimal segment. So I think that this is actually a really good choice in the situation to reduce the embolization risk. And then the other big benefit here is that then it does improve the outflow to be able to see what's going on. I would agree that if you're going to use some form of atherectomy device, even laser or directional atherectomy, I would probably use a filter at this point, but I don't think with lithotripsy that's going to be necessary.
Okay, so you feel that if you were going to use, just for the audience, just to reiterate, you feel that if you were going to use any form of atherectomy, you would have most likely put a filter because the popliteal is occluded and you don't want to lose the collaterals, but you feel that with lithotripsy may be safe given the mechanism of this device. So, Tomas, can you tell us a little bit about the lithotripsy and the length of the balloon? Is this the largest length you can get, and how long are you going to stay inflated and those kind of things?
Yeah, okay. So there's a standard length available with all large vessel balloons, which is 6 centimeters. For below the knee, the length offered is 4 centimeters. For the femoral popliteal device, we have different diameters ranging from 3.5 up to 7 millimeters. What we have chosen here is a 6 millimeter system. Sind wir schon bei 6? Machen wir noch mal einer. So what you can see over here, this is basically at the proximal and distal end, you have more or less radiopack markers. These are representing the edges of the balloon, and in between there are more dark gray markers, 5 each, on each balloon, representing the emitters for the shock waves, which are then emitted radially to the vessel wall.
Yes. Thomas, we are seeing those numbers on that on the right side of our screen. We're seeing some numbers. What do those numbers tell us? I see 210. What does that mean?
Yeah. Okay. So the work life of each single lithoplasty balloon is 300 pulses, and these 300 pulses are applied by cycles, treatment cycles, applying 30 of these impulses per cycle. That means in total, per balloon inflation or per balloon position, we can apply 30 times a lithotripsy to the lesion, and after 30 of these applied impulses, there's a short pause of 5 seconds, and the generator is then active again to apply the lithotripsy energy towards the wall. So we are applying pressure waves to the calcium, and in total we can run 300 impulses, meaning 10 cycles with 30 impulses each. So we have performed now 3 runs. That means 90 pulses had been applied to the most distal lesion, and I will give you a short angiogram here to show you the intermediate result of the treatment of the most distal lesion, which was at the level of the patella. Yeah. Go. So there is a complete resolution of this former eccentric 90% stenosis, and we have this eccentric calcified lesion at the femoral popliteal conjunction. I will show you the previous angiogram with the initial lesion here.
Right.
So
That's
this was
nice
really
result.
a very tight lesion. Yeah, and we did inflate the balloon maximum to 6 atmospheres. You may question now the diameter of the balloon, which is 6 millimeter. Isn't it too big related to what we may consider as being the reference diameter, which could be 5, it could be 5.5. I don't know. We don't have a real reference here because the artery is diseased from top to the bottom, and my impression and experience is basically that a male patient with normal body weight and height has usually a reference vessel diameter of 6 millimeter. And that's the reason why I've chosen here this 6 millimeter dimension.
Right. You know, just want to ask the panel, you know, there's a lot of push, especially in the coronary arena, in regards to intravascular imaging to try to understand better the sizing of these arteries. We learned from all the devices, you know, stents, balloons, that if you undersize or you oversize, our patency goes down. Art, what do you think? Do you think there is a role for IVUS, OCT, to try to have a better understanding? Even a guy like Thomas that has so much experience, he feels like he's guessing sometimes.
Yeah, I think, you know, we're using more and more of the IVUS in our lab, and we always sort of learn something that we didn't expect. So we definitely could use it more. We're using it a lot for sizing, for areas that aren't well visualized with angiography, if we're doing an osteal SFA or something like that. Even the iliacs for sizing, especially when there's size mismatch. But it's been very helpful for us, and sometimes you get in there and you get surprised. And it's always worse than it looks on the angiogram. You know, you end up wanting to fix a lot more when you do IVUS, in my experience.
You know, we went directly to endovascular approach. I mean, we didn't really discuss our approaches, and I know we have a few talented surgeons that do both bypass and endovascular. Just wanted to ask, you know, Alec and Steve and Norm, if they can comment on, you know, if you were to consider surgical approach here, what would those approaches be given the diffuse disease in the SFA and what we see?
Well, I think that certainly you'd want to achieve inline flow to the foot if possible. Certainly, if the dorsalis pedis is a good target, it appears to be, although I haven't seen a lateral foot shot, I would want to bypass into dorsalis pedis because I think the results probably would be better than the peroneal, if that was possible.
Where would you start your bypass graft? Where would it come from?
That would all depend on the length of available vein. So if the vein was available, I might start from the proximal SFA. If the vein was limited, I might treat the SFA endovascularly, as just done here, and then perform a popliteal dorsalis pedis bypass.
Does the disease bother you? I mean, the SFA is diffusely diseased, calcified, you know, as you can see here, they are working on it. Does that affect your proximal anastomosis or the options for bypass in this situation if you were to do a hybrid approach, let's say do angioplasty, stenting of the SFA and then consider bypass? Would that affect it or no?
There's a lot of evidence to support distal outflow grafts. In other words, grafts from the SFA distal to endovascular reconstruction. They work quite well. So no, I think in this particular situation, you could easily treat the SFA endovascular and then go down from popliteal. I think this might be very difficult to revascularize antegrade. So we'll see what happens.
See what happens, yes. Yeah, we're going to talk about that part. I agree with you. I think that the distal cap is a little bit ambiguous, as we discussed yesterday. So from the standpoint, so Tomas, so you're doing this, and educate me a little bit. Again, the length of time that you're up is based on that 300 pixel or whatever it's called. Is that correct?
Pulses. Yeah,
Pulses,
well,
yeah.
no, the recommended treatment strategy is to inflate the balloon for one cycle, meaning 30 seconds with 4 atmospheres, and then to increase the pressure for another minute to 6 atmospheres. Yeah. And after that, you have to reposition the balloon by about advancing the balloon or pulling back the balloon by about 5 millimeter in order to guarantee a homogeneous distribution of the acoustic shockwave energy towards the plaque. And so the entire balloon inflation time depends a little bit on your strategy following lithotripsy. Our strategy in general is to use drug-coated balloons following the vessel preparation with lithotripsy. So this does affect our strategy regarding lithotripsy. So we are inflating the balloon for 30 seconds for 4 atmospheres, then we increase the pressure to 6, leave it another 30 seconds usually, and then reposition it. And thereafter, we inflate our drug-coated balloon for the 3 minutes, which is our general strategy for drug-coated balloon angioplasty.
How important is it from the standpoint of apposition? You know, you mentioned the sizing, obviously. You decided to go with a 6 millimeter balloon. Do you suggest that folks are using lithotripsy to be a little bit more aggressive, like 1.1 to 1? What is your recommendation in regards to apposition, and how important is that?
That's really the key point for every kind of balloon-based angioplasty strategy, regardless whether this is lithotripsy or lithotripsy or drug-coated balloon angioplasty. You need to slightly oversize the balloon. It can be 0.5 millimeter, it can be even 1 millimeter. With this slight oversizing, you achieve the best acute and long-term outcomes. Best proven by the Levant 2 study, where we have seen if we undersize the balloon, that means a balloon to reference vessel dimension less than 1, this results to significant lower patency rates as compared to slightly oversizing the DCB. And this is also true for lithotripsy. In the Disrupt 2 study, we did look on different potential predictors of patency, and one of those was a slight oversizing of the lithoplasty balloon.
That's great. So while Tomas is working on that, let me ask the panel, let me start with Dr. Cummings. So Norm, tell me, let's say you don't have lithotripsy, you see the calcification, it seems like moderate to severe calcification, and you wanted to use some form of atherectomy. What would the choice of atherectomy be for you in this situation with this vessel?
Yeah, that SFA with the heavy calcification poses a challenge. I agree with the panel about putting a embolic protection device distal. I think that's very important when doing atherectomy in the SFA just about all the time. So you could try directional atherectomy here or orbital atherectomy. I think both would be reasonable options, followed by a drug-coated balloon.
Steve, how about you? What are your thoughts about do you feel like we need vessel prep in this case, or do you think this is overkill? And if you feel it is necessary, what would you use?
I'm a really big fan of rotational atherectomy with active aspiration, especially in these calcific lesions, with the intention of going through the CTO and the P2 and P3 segments, and ultimately try to revascularize that peroneal artery. You can use that one device to do all of that. If you happen to be in the subintimal plane, I think Jetstream can be safe off-label, but can be treated with the blades down. I would certainly use IVUS to kind of assess the position of the wire, but that's my strategy going forward with this type of lesion.
And in these situations, if when you use the Jetstream, how do you do it from a standpoint of blades down, blades up? How many runs of blade down do you do? And can you tell us your strategy when you use Jetstream?
Yeah, so the blades down modality is highly dependent on the size that you pick. So the XC or expandable cutters are available in 2.1 to 3.0 and 2.4 to 3.4 diameters. I'd probably start with a smaller lesion with the intention of treating the TP trunk and perineal artery. I would only go blades down unless I'm absolutely confirming a true luminal positioning of the wire, at which point I would consider a blades up strategy.
Right. Dr. Nizal, what are your thoughts about this case? As you can see, I think Tomas had decided to go antegrade. Would you have gone for this case antegrade, or would you have gone up and over? What's your access strategy in this case?
So perhaps I'll do both actually. Go antegrade in order to improve the inflow, which is more important now in case we fail to go distally, but I will try also to go distally at the same time in the same sitting.
Right. So Tomas, what's happening now? So I saw you took out the balloon and the wire.
Yeah, well, exactly. Yeah, I have now introduced a 5 French diagnostic catheter. It's a vertebral configuration, and our next step is now to try to reopen the vessel, the popliteal vessel, to find an entry into the occlusion. And this is now a right oblique projection. And you may see here in this digital subtraction image that we have in total 2 big genicular vessels originating here from the stump of the occlusion. And the key question is, are those both originating from the same origin, or is the most proximal and separate offtake, and the more distal one originating from the distal occluded popliteal artery? Ein 35er Terumo, bitte. Nein, 35er. Ein 35er. Ein 35er. What you see here, this is now without subtraction, and it seems that we have 2 different offtakes of those genicular arteries. So the more distal collateral is taking off of the popliteal artery according to the calcium shadow we do see here. And this will now guide my effort to penetrate into this chronic occlusion. As mentioned, we know from historic angiograms we had been provided by the referring hospital that 5 years ago the first angiogram was performed, already showing here a CTO. So this is a really chronic problem, and for that purpose I'm not starting with a low profile guide wire. I'm going directly in here with a stiff Terumo 35 guide wire, simply to have the option to penetrate into the occlusion, which is pretty much calcified. And you can see here, this is not the
so Thomas, would you consider
the popliteal artery? It's simply the collateral vessel where the guide wire is entering in, and the challenge here will be really to find a way into this collateral vessel.
So while you're doing that, let me ask the panel a couple of questions, because this is a great case, and I think for our audience. So when you have an ambiguous cap like this, what are the options? Dr. Nazal, you wanted to suggest something?
Yeah.
Ambiguous cap.
My question, this is really a natural bypass, very large geniculate artery that almost a bypass distally. Why not to improve the flow, the inflow in that bypass and call it off, rather than worrying about embolization and ruining those vessels?
Right. I mean, I think that was the question we asked originally. Let me ask the panel what their opinions. Tony, what do you think? I asked that originally. So the question Dr. Nazal is suggesting is that why even open up the pop? Those geniculars seem to be decent size. Why don't we just fix the inflow and forget about the rest and hope that things will heal?
Well, that's one strategy, right? You can separate this into two procedures, obviously. I think for demonstration purposes, they're doing it together and doing a very nice job of it. But I would agree that one option is to treat the inflow, see if the ulcer heals, because Tomas did mention it was a relatively small ulcer and potentially the geniculate collateral inflow would improve. It's interesting, though, his technique. He was able to find the ostium, and the wire loop is relatively small up until this popliteal segment. I think his options here are that he has probably found the opening already. So the key here, the only thing I would have done differently is spend a little more time identifying the cap. I think that Tomas has so much experience that in one view he was able to really tell. But this is a case where I spend a lot of time on, basically rotating the camera, making absolutely sure I understand which is the cap and what's the best option, because sometimes you only have one shot at the beginning of this.
And the last thing you want to do is to potentially damage the collaterals and not be able to cross. Now you took the patient to maybe rest pain or made the situation worse. So Art, tell us, what the technical aspect of this. Once you have engaged the cap, tell us about the loop. How big should it be? How careful do you need to be to cross this popliteal artery?
Yeah, no, I agree with Tony's comments. I think I might have stopped and done a toe pressure if it was a small ulcer and just seen, because the below knee anatomy is so delicate. But I think more images to see if you see a nipple or a beak to start, and then I probably would have started with a smaller system, not to dissect and ruin those collaterals. But obviously Tomas has great skills and he's getting across here. I was thinking for this case, I probably would have gone quickly to the retrograde so I don't, ruin those collaterals. Perineal, DP were open, but again, you don't want to ruin those vessels either. But so I might have actually ultrasounded and seen the distal AT or PT, but probably the AT. If I could see the AT, I might access the occluded segment, see if I can open that up into the pop, get across, and if I could, then complete into the DP is one option.
Okay, Tomas, go ahead, tell us what's happening.
I have some trouble in hearing your comments, so I have only some interrupted connection. Can you hear me?
Yeah, we can hear you very well, Tomas. So basically, I can give you a quick summary of 20 seconds. The panel is in...
the tone is lost again, but if you can hear me, my comment regarding the ongoing discussion. I did evaluate the anatomy already from the very beginning doing my first injection, and it was obvious that we would need an oblique projection to identify the correct course of the occluded popliteal artery and to identify the origins of the collaterals, which is definitely essential to be able to cross this occlusion from an antegrade access. I was also already prepared for a retrograde access, which would have been my alternative second approach here to cross the occlusion of the popliteal coming from the peroneal artery. This artery has a relatively big diameter distally. I would assume about 2.5 millimeters, and there is a lot of native calcification, so it would be pretty easy to puncture the peroneal if necessary. But now I believe that we should be able now to find a way back into the peroneal artery via the antegrade access.
Yes. Well, that's great. Can you hear me okay, Thomas? Can you hear me?
Yeah, now it's, yeah, I can hear you.
Okay. Well, the panel, we had a little discussion about your wire technique and how big the loop should be and those kind of
the
things.
first step was obviously to use the straight tip of this angulated 35,000 guide wire in order to penetrate into the occlusion. After having achieved this access to the lumen of the popliteal artery, which is obviously subintimal because of the severe calcification of the occluded vessel segment, I did create a loop. And my intention was to keep the loop as small as possible in order to avoid any kind of perforation and in order to, in particular, jeopardize the tibiopenial trunk. And this is also the reason why I did now relieve this loop, and I'm trying now with the tip to find my way towards the peroneal artery. It's not my first choice usually to use a 35,000 guide wire for this attempt here. It's simply trying to probe a little bit whether I can find easily the way into the peroneal. If not, I will downsize the wire dimension and go or start probably with a 18,000 guide wire to find the way back. So here, no, it's sometimes I have the impression that I may be already in some lumen, but it's not. The other option would really be to preserve the loop and to try to push the loop down to the origin of the peroneal artery in order to disrupt the intima and media layer and find the way back into the true lumen with the loop technique. But I'm now here in this side branch or in this
great job.
branch of the peroneal.
I just wanted to highlight the fact that
I will forward. Yeah. Yeah, go ahead.
I was just going to say, I wanted to highlight the fact that you are being very careful with the wire. You are very patient, and you just keep going back and forth and rotating, trying to find that channel to get you to the true lumen.
Yeah, so now I did remove this 35,000 guide wire because I'm pretty confident that I created some connection from the subintimal channel from the TPT into at least this side branch of the peroneal artery. And I will try to inject some contrast medium now to verify if I have a real connection here. Oops. Okay, so there is some connection. I'm not sure if it's really already accessed to the peroneal. I will switch down now to an 18,000 guide wire.
And what is that wire? What is the name of the wire you're going to use?
Den Kommentar habe ich nicht verstanden. Yeah.
Can you hear me?
So what I will try now is to probe with the 18,000 guide wire. If this fits, then everything is fine, and I would suggest to go then to switch to the other cath lab because they are also ready to present you at least the case and the baseline angiogram. So the guide wire is not free. Kann ich einen Talker haben, bitte?
Thomas, what wire is this, if you can hear me?
Yeah, this is the Advantage 18 guide wire from Terumo.
Okay.
I did not use directly my usually preferred 14,000 guide wire here, which is also the Advantage 14 from Terumo. I start even in calcified lesions below the knee in calcified CTOs, usually with, now I'm in,
There you go.
with the 14,000 guide wire, but now you can see the tip of the guide wire could be rotated freely, and I'm simply following now with this support or with this diagnostic catheter to get access here to the perineal. So I would say the most important step here is done. The next steps will be pre-dilatation of the occlusion, now using a regular balloon, because I'm not really convinced that the application of lithotripsy in a subintimal space is really effective. So the next steps will be pre-dilatation with a plain balloon, then potentially stenting of the TPT with a drug-eluting coronary stent, and of the P3 segment of the popliteal with a superior stent. For that interventional steps, we will be back, and we would like now to switch to the other lab if you agree.
Okay. Sounds good. Thank you so much. That was very nice, the way you wired that lesion. I think to emphasize is how meticulous he was, especially at the distal cap. Any comments, panel, about his technique and if you have done anything differently?
I think it's really important for us to understand the kind of genius level skill that Professor Zeller has, and maybe we can comment a little bit about wire escalation techniques and those mere mortals that do these cases on a daily basis.
Okay, what do you, Art, wire escalation technique?
Yeah, I mean, I think, he looped it and got into the pop really nicely. I might have gone with a smaller wire there, but that's great because you're in the architecture of the vessel. Once I was there, I would go to exactly what he did, but maybe a smaller wire, not loop it. You don't want to make that dissection plane too big, because if you can't cross and you need antegrade, retrograde crossing techniques, I think cart, reverse cart, double balloon, they all work better with a tight subintimal space. So you don't want to make a big loop and make that a big space.
Norm, given the ambiguity of the distal cap, I mean, we said that we would take different images. Would you have considered retrograde in this situation from the beginning and say, you know what, this is very ambiguous, I cannot find the cap, let me just go retrograde and do this in a retrograde fashion? Or do you always try to at least something antegrade?
I usually do try to go antegrade first, and you never know how much calcium you might have in there or how much thrombus is in there that may make it easy to go from an antegrade approach, and then if it fails, then switch to a retrograde approach.
Okay, Dr. Nouriz, good morning. We are all here and excited to hear from you.
Good morning to the audience, good morning to the panel. My name is Elias Nouri, and I'm here with my colleague, Dr. Boksha, and he's our fellow and will assist me during this case. Can we have our slides, please? So the next case will be here BTK artery disease, diabetic foot syndrome. This is a 78 years old female patient with a PAOD, according to Rutherford 5, with a non-healing ulceration at digitus 1 and 2. She has also three-vessel coronary artery disease. She had a myocardial infarction in October last year that was treated with PCI last year, but also 2 times more, 2009 and 2002. Her risk factors are arterial hypertension, diabetes mellitus, and hyperlipidemia. Next slide, please. So the non-invasive imaging showed ABI at the right side 0.6 and at the left side 0.8. The duplex scan showed a diffusely diseased SFA with a 60 to 70% stenosis of the middle part of SFA, but also diffusely diseased BTK arteries. So the duplex scan showed an occlusion of the anterior tibial artery and high-grade stenosis of posterior tibial artery. And our procedural steps, we already prepared with an antegrade approach, 6 French sheath, And the first step will be to treat the femoral popliteal artery, and then I will show you a selective angiography from the below the knee arteries, and then we have to decide to open one of the vessels according to the angiosome. And we can discuss about the treatment. We know just at the moment we don't have not really evidence for drug-coated balloon angioplasty for below the knee arteries, but we have some registry data which was presented also at January at Link, Dr. Goa, with the new Acutec DCB balloon, which really nice results, better than POVA, so we can discuss about the treatment. And another option is clearly in case of short lesions that we will cover this with a drug-eluting stent. But we can change now at the live screen. Do you have some questions at this moment?
No, I think if we can see the angiogram, it'd be great.
Yep. So the first baseline angiography showed a diffusely diseased femoral popliteal artery with 60 to 70% stenosis. There is some calcification in the popliteal artery. In the SFA, there is not really severe calcified, but at the middle part of popliteal artery, there is some calcification. And this is now a selective angiography from below the knee arteries. There is an occluded anterior tibial artery, a short occlusion of the peroneal artery, and a long occlusion of the posterior tibial artery. So the next step will be as first to treat the femoral popliteal artery. And the question is how to treat lesions like this case. Long lesions, there is not much calcium. There is in the popliteal artery calcified, but not in the SFA. And we know that drug-coated balloon angioplasty has a very nice result, and it will be also our strategy to cover the lesion with drug-coated balloon. But what's about the preparation of the vessel? So do you would make us first an atherectomy? Would you use or recommend litoplasty, which was showed now just before by Thomas Zeller? We have some options, or just pre-dilatation with POVA and then followed by DCB.
Great question. If you can show us the angiogram one more time, I'm going to ask the panel. So let's see here, Alec, what do you think, this SFA? The question is, how should we treat this SFA? The mid-SFA.
In our practice, we would perform angioplasty, plain balloon angioplasty for long time inflation, 1 to 2 minutes, and see what we get. We have stopped using DCBs for the SFA, given what has been happening with paclitaxel. If there is a restenosis or recoil, I would probably deploy stents.
How about drug-eluting stents? You don't use those either?
We use coronary drug-eluting stents, but we have stopped using paclitaxel drug-eluting stents for the common scenarios.
Right. Anybody else on the panel has moved to that direction? Let's go one by one. I think this is an important question the audience wants to know. So, Tony, what's been your approach now with all these news about the association between DCB and mortality? As you know, many folks have a lot of concerns that this is just a statistical association and not a causal relationship. And multiple analyses has been done. I know your group, Viva, has been very at the forefront of this. What are your comments?
Yeah, I mean, it's obviously a important discussion. I think that what we've learned so far is that the patient-level data suggests that there may not be a real implication here. But I think I agree with Alex's caution, but still understanding that we haven't taken these off the shelf, but we are more cautious about the situations in which to use them. And the general recommendations are lesions with a high risk of restenosis or patients that have already failed balloon angioplasty. We're clearly still using them in these long segments. Now, this is a long segment, which to me has a high risk of restenosis. As we know, the statistical patency of this is going to be about 30 to 40% over the course of 12 months. So I would probably do POBA, not atherectomy, because it's not heavily calcified, and then follow with a long drug-eluting balloon, and then treat the tibial section.
Before I go to the rest of the panel, maybe you want to tell us what you want to do and get it started so I don't slow you down. And then I can go through the rest of the panel. What did you want to do? What's your strategy?
So my strategy is to make us first pre-dilatation with a 5 millimeter balloon, followed by drug-coated balloon angioplasty. And at the popliteal artery, we can also discuss about lithoplasty, but in this case, I used just a cutting balloon as pre-dilatation, followed also by drug-coated balloon angioplasty. And if you agree, I can show you the pictures. So this is now just before plain old balloon angioplasty. This is now the placement of the pre-dilatation balloon catheter. Pre-dilatation at 5 millimeter without dissection, and then was followed by 6 millimeter DCB 150 long Ranger balloon catheter. And this is now the result, which looks not so bad. And the next step was to prepare the calcified segments of the SFA and also the popliteal artery. And this is now a cutting balloon, 5 millimeter by 20, that was completely open, followed by DCB and also the middle part. And now I can show you the results after cutting balloon and after DCB from above to popliteal artery. Oh, what one?
Great. While you're taking the angiogram, I'm going to ask Steve. Steve, so going back to the same question, this issue of this SFA, what would be your algorithm in the current era?
I think there's a lot of debate about the mortality signal, but what there is no debate about is the driver for cost around the world for these procedures, which is TLR. So an anti-proliferative strategy, I think, has to always be considered. When we're talking about somebody that has Rutherford 5 or CLI, there's no question that the driver for mortality here is going to be the patient's disease process and not paclitaxel. So there's no question I'd be using an anti-proliferative agent. In a TAS 2A or B lesion in the SFA like this, I'd be using a DCB.
Great. How about Art, you?
Yeah, I think I agree with Tony. It's a long lesion, diffusely diseased. I think the restenosis rate is significant here. You know, we've been talking a lot more to our patients, had a separate consent form for the last few months, and then just the last month relaxed that a little bit. But I think it depends on the conversation with the patient, how comfortable they are with it. But I really personally don't have a whole lot of problem using it in appropriate situations. Some of the thinking in our lab has gone back to sort of pre-DES days where if you're going to do something not drug-based, then maybe try to leave the vessel native. So we're from the atherectomy state, Florida, so we would have done atherectomy here. Maybe a hawk, you know, just to get a better balloon result, less dissection, less need for a stent. And if it was a good result, I might follow up with a DCB like they did. If there was significant dissection, you know, we're using a little more supera, but still using plenty of, you know, PTX in our lab.
Peter?
Yeah, I think I would have gone with a DCB strategy here. Again, it's a CLI patient, diabetic, long segment disease, high risk for restenosis. So I think that the benefits of antiproliferative therapy are outweighed. As Steve mentioned, I mean, we know that patients with CLI have a 40–50% 4-year mortality. So let them die with their leg on is my philosophy. So I would have done DCB here for the SFA disease. The popliteal disease does have some significant calcification. So if I could get through that cleanly, I think I would consider lithoplasty for the distal stuff. Again, it's a diabetic patient with renal insufficiency. You know that there's a significant calcium burden there. So, and then if there was a bad dissection, would have a very low threshold for bailing out with a coronary drug-eluting stent for the below knee. And then if I had to put a stent behind the knee, I would probably use a superior.
Great. Dr. Nizal?
Well, I will do actually what was done. I'll do pre-dilatation with a smaller balloon, high-pressure balloon, and then I'll use DCB. Although the literature is talking about it now, we don't have really great evidence that it's causing a problem yet.
Norm? I know what Norm would do.
Yeah, I have to agree with those comments. I mean, our own philosophy is to avoid stents in nearly all situations in the femoral popliteal segment. The data for DCB did not include patients with Rutherford 5 and 6 disease, mostly healthy claudicants.
Okay. Let me just take a quick poll from the audience, and then we go back to Dr. Nouri. Anybody in the audience has completely stopped using DCB and DES? Completely stopped? Anybody? Okay, so there are a couple of people in the audience that have used it. Anybody has modified their approach, so maybe not as aggressive. So majority have modified to some degree, but only 2 people have completely stopped. Alec, I think you wanted to say something.
Yeah, just to denote that in patients with CLI who have wounds, the really primary thing is to make them heal their wound. So long-term patency, although of course is always desirable and important, is less relevant than actually having them heal the wound. It's a very different situation for claudication or ischemic rest pain. And the other thing to consider with DCBs is, we haven't talked about it here, but the medical legal issues and the risk that you take if you use DCB in the United States these days.
Right. Yeah, I mean, a lot of the things we do have a legal ramification. I mean, I'm sure we put IVC filters and many other things that we do for our patients. I think communicating with the patients and building a relationship, having a good consent. And I think yesterday Dr. Shomas was on the panel, and he has a law degree in healthcare, and he was telling us and educating us about the standard of care. And the standard of care basically is defined by what we do. It's not really, so what is the masses do? And I think when we say raise hands or ask the panel, and majority of panel feel that still the benefit outweighs the risk, I think that's supportive as long as you have a good consent. So Dr. Nouri, tell us, now you go into the complex part below the knee, and looks like you were wiring was it the peroneal or the PT? I didn't pay attention, I'm sorry.
So exactly, this is now the peroneal artery, which was now crossed with a 0.14-inch wire intraluminally, and the next step will be to make a dilatation. I have now a 2.5 millimeter balloon catheter, and I would make a dilatation for 2 minutes at the occluded segment, and then we can make a decision to open the second vessel, the anterior tibial artery.
So how did you make that decision, Dr. Nouri? You have a couple options there. Was it based on the ease of wiring, or is it based on the fact that the blood flow or the ulcer? How did you make that decision to go after the peroneal?
So the reason was really because, as you can see here, this is a short occlusion. It is a diffusely diseased vessel, but there was a short occlusion. And after the recanalization, maybe I have a better feeling of the posterior tibial artery, also dorsalis pedis. And I can then, in the second round, I can try to open the anterior tibial artery or the posterior tibial artery. I would prefer, according to the angiosome, the anterior tibial artery, but we have also the option, if it isn't successful, to open the posterior tibial artery. But the reason was clearly the short occlusion of the posterior tibial artery.
And when you do this TBL work, do you do staged inflation of the balloons, meaning you start with a smaller size and gradually upsize, or do you use the size that you think is appropriate as the first step? What's your approach in regards to angioplasty, and how long do you stay up? Tell us about angioplasty.
So, dependent on the lesion characteristic, if there is a lot of calcium or there is a media sclerosis, so I would take as first a smaller balloon just to go through and make as first a pre-dilatation, and if there is a nice result, I can follow with a bigger or 0.5 millimeter bigger balloon. Our strategy is clearly to avoid a long dissection or a spiral dissection, and that means to go very carefully with the pressure, slowly higher, like in this case which I showed you, and you can see also the expansion of the balloon. I think in this vessel is 2.5 millimeter is maybe correct size, so it could be a little oversized, but we can see it now after
Great.
30 seconds.
While you're doing the inflation, let me get some, I'm sorry, go ahead.
Exactly. We will make for POBA or for plain balloon angioplasty below the knee for 2 minutes. And in case of using DCB, we will take it. We will leave it for 3 minutes. But as I heard in the US, so the majority of hospitals stopped the use of DCB, so we didn't change our strategy according this paper and according this decision from the FDA. But I think in this case, in CLI cases, I think that would be better to use a DCB, especially in long SFA lesions with a very high rate of stenosis. It makes sense to take a DCB.
Yes, thank you so much. Let me ask the panel, Steve, any tips and tricks about angioplasty below the knee? We know that that's made our mainstay of therapy, so give us some advice.
Well, I know that in Germany there is some reticence in using intravascular ultrasound, but below the knee in our lab we use it pretty much routinely for the purposes of identifying the position of the wire, the size of the vessel, and plaque morphology, the appropriateness of atherectomy. I usually use long balloons, 220 millimeters on average, and size the balloon according to the IVUS, 3-minute inflations.
Right. And have you, since you start doing that, have you learned that maybe you were undersizing in the earlier days when you weren't using IVUS? Like, what's been your experience now that you're an IVUS-based operator?
I can tell you without hesitation that probably 80% of the time my decision to select a size of a device was completely altered by the use of IVUS.
Wow, that's amazing. I mean, how many people in the audience are using IVUS for sizing? So few people, but I think that this intravascular imaging, I mean, we know there is a lot of data regarding, residual stenosis after the angioplasty or stenting and patency. So I think any other tips from the panel regarding below the knee treatment with angioplasty, Dr. Nizam?
So I usually go with the smallest balloon, worrying about dissection. I think the enemy in distal arteries dissection because you try to avoid stent as much as possible. So then I do an angiogram. If it is satisfactory, okay. If not, I go with a higher balloon.
Right. Right. So gradual. If folks have suggested using a gradual approach, maybe go with if it's a 3.0 vessel, consider 2.5 angioplasty first for a prolonged period, and then see how it looks, and then go to 3.0. That's another approach. I think IVUS is more precise, but that's another approach. Tony, you have a lot of experience in this. What do you suggest? Any other thing you can add to this?
No, I think that the main thing is making sure that you actually get the vessel completely open. So I think that one of the points I think Steve made was what the IVUS also helps you with is the severity of calcification. Sometimes we underestimate how much that is. And underinflating a balloon typically leads to rapid recoil issues. So identifying when you really need to do some vessel preparation is probably the one other piece I would add to this.
Peter, let me ask you a question regarding which vessel we should open. How much thought process do you think needs to go to that? Like, you know, in this situation, he could have done the AT, he could have done the PT. He decided to go for the peroneal, as he explained, Dr. Nouri, because it was a shorter occlusion, and that would give him better pictures after opening the peroneal to see the AT and the PT. How much thought do you put into deciding which vessel am I going to open, and how do you decide whether you're going to go just with one artery or versus 2 or 3?
Yeah, it's obviously has to be an individualized decision. And although the angiosome concept is very helpful, we know that even indirect revascularization benefits patients. So there's the theoretical aspects to consider, but then there are also the practical aspects of you want to do the procedure safely without too much contrast and avoid injuring the patient or making them potentially worse. So there was a nice entry into the anterior tibial. I might have tried the AT first because that was the target angiosome. But I certainly wouldn't have any, and I certainly don't have any problems with going after the perineal because, again, it was stenotic, it was a straight segment. It's going to obviously provide additional collateral filling to both the DP and the plantar vessel, so I think it's completely reasonable to do the perineal. But again, if I'm going to get a second vessel in this particular case, because of the angiosome concept, I would agree with going after the AT.
So let me ask Norm a question. Norm, let's say I just graduated from my fellowship. Somebody refers me this case. I don't really want to say no because I want to show them that I'm, well-trained and I can do these complex cases. Is there anything wrong with me doing the SFA and then staging, taking good pictures of below the knee, and then staging the case to come back a week later or so to do the below the knee? Or should I do the whole thing, like they're doing here, Dr. Nouri is doing?
Did you listen to the professional?
The total benefit of
Tom?
doing angiographic interventional approaches versus surgeries, you can do it piecemeal. You can do as much as you want safely, stop, come back. If you're not comfortable, you could get somebody more skilled to give you a hand, especially when you're first starting out. You don't want to have bad outcomes as when you're starting out and hurt the patient or ruin that tibial vessel or burn bridges for later.
I think that's a great point, and Dr. Das, yesterday really gave us a great lecture. So, Dr. Nouri, tell us what's happening. I saw the peroneal looked very nice. Give us an update,
exactly.
please.
So, I already made a plain balloon angioplasty from the middle part to distal and opened this vessel, and I can show you now the result. There is a nice flow without relevant residual stenosis, and we can see now the very good feeling of the plantar arch. And the next step will be now to go the anterior tibial artery and open the second vessel. And but I think Thomas Zeller is now also ready to show you the result of the intervention, and we can change the cath lab now and see you in a few minutes.
Can I ask you one quick question before you leave? You have such a beautiful result. You have fixed 2 levels. You fixed the SFA, you fixed the peroneal, you have good collaterals to the PT. What is your urgency in regards to opening the AT, and is it worth seeing how the patient does and considering coming back? I'm just asking for the audience your thought process.
Yes. So it is. I agree with you. So, in the majority of cases, or especially in cases with patients with kidney failure, it would be enough, and I will leave it here in this step. But in this case, I would achieve a better result because it's a CLI patient, and according to the angiosome target, is the anterior tibial artery our target or our better vessel to achieve completely wound healing. It's completely correct with a very nice collateralization over the perineal artery, but I can just try, and if it is really complex and it's a CTO, it isn't possible, I would stop then the intervention and just wait for 4 or 6 weeks. And in case of non-healing ulceration, then we can do a second procedure and try to open the anterior tibial artery from antegrade and maybe pedal or tibial approach retrograde.
Great job. I think you did a fantastic job with that case, and we appreciate your work.
Thank you.
Okay, we go to Thomas, see what is he doing. I think they're waiting for the lab change. You know, what do you think, Art, in this situation? Would you have gone after the AT, or, I mean, it seemed like they had a reasonable result.
Yeah, you know, I had trouble seeing. There's no DSA, so
Yeah.
I had some trouble seeing. I wasn't sure if the TB trunk was diseased or not. I like to stage these, especially if I'm doing multi-level and if I'm up and over. So I like to go antegrade if I'm tibial. So I probably would have stopped here.
Thomas, we are here. Your partner, Dr. Nouri, did a great job. He opened up the SFA and the peroneal. Tell me what you're doing.
Yeah, well, we did great progress so far. I will just guide you through what we have done in your absence. Just a second. Yeah, well, this is after pre-dilating the popliteal artery and the peroneal artery with a 4 mm balloon. What you may appreciate here, this is, we have haziness at the level of the patella. What you can see over here, this is calcium. And then we have the dissection, a kind of spiral dissection going through the entire distal popliteal segment down into the TPT. And this was then followed by switching to 14,000 guide wire and the placement of a 3.5 by 48 millimeter drug-eluting stent. It's a coronary stent. And this is, we don't have yet the angiogram after placement. It's a synergy stent. And then the next step was to dilate the popliteal segment for superior stent placement, so to prepare the popliteal artery for the intended superior stent placement. But we realized that just at the level of the entry into the occlusion, the 6 mm balloon we did use for pre-dilatation did not fully open. So we decided to use a second shockwave balloon, again 6 mm. We did about 8 runs, 30 pulses each. So we applied about 240 pulses, and this is then the result after lithotripsy. You can still see the spiral shape of the subintimal channel. At the lower edge, there is the location or the proximal part of the stent, which is placed into the tibioperoneal trunk. And this is now the release of the superior stent, which is a 5.5 by 100. And we are just post-dilating this stent again with the 6 mm lithoplasty balloon. We did inflate this balloon even up to 10 atmospheres now, and this is the current state. I did order a high pressure balloon because we still see some compression of the stent. So the stent expansion is not yet optimal. But anyhow, after removing now this lithoplasty balloon, I will give you an intermediate angiogram before I use a high pressure balloon to further upsize the superior stent, that you get an impression where we are at the moment.
Thomas, did you use DCB before Supera or no, just a shockwave?
No, shockwave and plain balloon,
Okay.
yeah.
Okay.
I will use DCB for the SFA later on to finish the procedure.
Yes. So let me, while you're taking an angiogram, let me ask Art to comment on the vessel preparation for Supera. Art, can you tell us a little bit about that? Because I think that's critical.
Yeah, you know, Supera is a great stent for a lot of reasons. It has a lot of resistance to being crushed, but the vessel also need to be prepped well because the deployment is obviously easier if you can expand, and also the patency results are very dependent on you know, elongation, compression. You want to have the ideal deployment and get the best patency results. So again, you know, pre-treatment with atherectomy or high pressure ballooning, just to make sure you can expand it, is really important for Supera implants.
And Peter, from a standpoint of sizing, we know that it comes in half sizes. How do you size Supera? And what are some tricks in regards to deployment you can tell us about, so we don't get elongation and invagination and all those nasty things?
In order to avoid the dreaded elongation that Art was mentioning, the vessel prep is really key. So for example, if you're going to be putting in a 5.5 Supera, you would want to pre-dilate that with a 6 millimeter balloon. And you know, the other thing to keep in mind is, although it does say that it's a 5.5, that's sort of the outer diameter of the stent, but it's going to be a little bit less on the inside. So in general, if I'm trying to decide between a 5.5 versus a 6.5, I'm going to usually err on the side of taking a 6.5. I think the long-term patency data is better. But vessel prep is absolutely mandatory. You can't put a 4 millimeter balloon and then put in a 5.5 Supera. If you're going to put in a 5.5 Supera, you gotta pre-dilate with at least a 6 millimeter balloon. And you have to go, and this is one case where radiation be damned, I'll usually mag up and I'll deploy it very, very slowly. And I'll keep a little negative tension on the entire system with my left hand. And if it looks like I'm starting to elongate a little bit, I'll kind of pinch the shaft of the device so as to thwart that elongation effect. And the flip side to that is, if it looks like you're starting to stack up a little bit, then you need to put a little bit more negative tension on the device with your left hand so that you get a nice smooth deployment. And the key really is to take your time and do it well and really visualize in real time as you're deploying the stent to achieve an optimal result. Because if you don't adequately pre-dilate, and if you allow the stent to elongate, you may find that your 80 millimeter stent all of a sudden came out of the package as an 80, but it's now 160 in the body. So vessel prep and proper sizing are really critical.
Tony, any comments about considering, doing DCB for antiproliferative purposes and then placing Supera? I mean, we usually use Supera for situations where we think behind the knee, where there's a lot of tortuosity and a lot of flexion, extension, and those kind of things. What are your thoughts about that, especially, let's say, before the era of all these concerns? Do you think this is a reasonable option?
Well, I generally wouldn't treat it as a primary strategy, but we end up in that situation frequently where you're trying to avoid stenting in a relatively calcified segment, and you've prepped it with a plain old balloon angioplasty at the popliteal segment, and then you've done DCB because you want to avoid a stent, and then you end up with a Supera anyway in that situation. That would be a more likely scenario than the opposite, because if the case is that you really want to put in drug, then put in a drug-coated stent for sure. One of the other things about the big difference, obviously, that people know about Supera versus regular self-expanding stents is that there's no chronic outward force on a Supera. This is a highly radially strong stent, like a stiff straw. So you want to make the vessel as big as it can be and then place the straw in there, because it's only going to be the size it is. So the problem that you run into is what Tomas is dealing with now, which is if it doesn't completely deploy, you really have a hard time trying to get the vessel to be prepped after the fact. So really over-prepping is probably better than under-prepping.
So preparation is the key, I think, when it comes to the use of Supera. So Steve, what are your thoughts about drug-eluting stents? We've talked about DCB, we've talked about Supera. Can you give us some insight as to DES? We now have 2 approved devices, Zeller and Eluvia. What is your selection process, and how do you fit that into this kind of a patient?
So we know that there is a head-to-head comparison from the Imperial trial showing superiority with Eluvia. In my lab, we do not use Zeller PTX anymore because of this. It is a really compelling data set that shows long lesion subsets, heavily calcified lesions. Even in the absence of vessel prep with atherectomy or shockwave or something like this, you have exceptional patency rates. And so that is certainly what I would consider kind of best practices, standard of care workhorse device for a lesion like this below the knee, where we don't really have data. I think it would be something that I would think about maybe using what Dr. Zeller used in the Supera. But even in the master's hands here, you can see some elongation at the P3 segment. Very difficult lesion, but again, I think with the antiproliferative options that we have available, Alluvia's got to be considered the king.
Norm, tell us about, when you decide to go the DCB approach, right? You have done angioplasty, results look reasonable. You do DCB, and now you see that there is an area of dissection. What is your bailout stent approach in those situations? Do you go with a bare metal stent? Do you go with a drug-eluting stent? What is your bailout strategy when you have used DCB and you have a dissection, and let's say you're in a mid-SFA, proximal SFA?
So usually I would go back in with directional atherectomy and take out that dissection flap. I found that to be very effective. I rarely place bare metal stents into the femoral popliteal segment, although the Alluvia data is very compelling and may change practice.
Thomas, we have about 10 minutes, 9 to 10 minutes, Thomas. So I see you are post-dilating that area of the Supera. So give us an update.
Yeah, well, we have now a coronary balloon. It's a quantum balloon which can be inflated up to 24 atmospheres, deflate here. And we are trying to dilate now, in particular, this area where we have incomplete opening of the superior stent, despite really, I would say, appropriate vessel preparation with lithotripsy. We did about we applied about 300 pulses, shockwave impulses, and despite that we have still this residual stenosis, 20 atmospheres now. So what is very important, if you post-dilate a superior stent which is not fully expanded, is take your time, and it can be even 1 minute you may need to fully expand the stent. So it's not simply a 10-second balloon inflation. It takes even longer. Yeah, we have some problem here with our indeflator. It does not really accept the high pressure. Don't know what happened. We probably need a new one. Kriegen wir noch mal einen neuen Indeflator? No. It's jumping back at 20 atmospheres. Yeah. So what are the next steps? Well, it's definitely to work a little bit on a better stent expansion over here. And number two is we will, as mentioned, perform this drug-coated balloon angioplasty of the distal and mid part of the SFA. We have already treated the proximal popliteal with a 6x150 impact admiral, and then in addition we will use a 2.5 millimeter balloon, a long balloon, for the peroneal artery. So before we switch back to the other lab, I will give you now the interim angiogram of this case so far. Just a moment. Okay. So, yeah. So you can see at the level of the adductor channel, the result is already satisfying down into the P1 segment.
Right.
Proximal of that, we have still an eccentric stenosis, which will be treated with another 6x150 millimeter impact admiral. And then I will show you the outflow here. Next. Go. This is now the popliteal segment and the TPT. Where we have still disease is the proximal part of the peroneal artery. This will be treated, as mentioned, with the 2.5 millimeter balloon. And then we should be finished and the patient should do fine.
That's great. We have about 8-9 minutes, Tomas. Any word of advice you have for us in regards to this case? Are you happy with your approach, or would you have done anything differently?
Well, having now seen the outcome of extensive lithotripsy in this case here, maybe an atherectomy approach coming from the true channel into the subintimal channel at the P2 segment may have been the better choice, or probably trying to use a cutting balloon. This would be another option here. I'm not sure what strategy would have been the better one here. Besides that, I believe I'm pretty happy with the result. It's not yet the final result, but we will end up with our intended outcome, which is to reestablish straight line flow into the foot, meaning we have a very big perforating artery originating from the peroneal artery to the dorsalis pedis artery, and this will guarantee wound healing. I'm pretty confident.
Right. Tomas, what do you usually do with your sheet? I think you have an antegrade sheet, if I'm not mistaken.
Yeah.
Do you close these, or do you do manual for these patients?
Yeah. No, I usually do close them with a closure device. In our country, or at least in our institution, Femoral is the favorite. It's a device which also uses a kind of anchor system, but there is no collagen plug applied, so the risk of vessel occlusion or inducing a stenosis at the puncture level is less than with Angioseal. So Femoral would be my choice here, and we will finish up with this closure device after having finished the procedure.
And can you tell us, maybe for 1 more minute, what is your antiplatelet and your any diagnostic workup that you, tests, hemodynamic test or ultrasound, anything that you do before the patient leaves, and when do you bring the patient back after the procedure?
Well, if we combine DCB and stent, we recommend dual antiplatelet therapy for 3 months now. I have implanted a long coronary drug-eluting stent into the TPT, so we will extend this recommendation to 6 months. And every patient will undergo duplex examination, ABI measurement, and also oscillometry down to the ankle level before discharge. That's standard of care in our institution.
That's great. Tomas, fantastic job. Thank you very much. We really enjoyed it.
Thank you.
We appreciate your time. We have about 5 minutes, maybe if we can have the panel to stay, and we can ask a couple questions. In regards to these cases, complex CLI, as was shown, what's your approach, Alec, in regards to prepping the leg if you have decided to go endovascular? Do you clean the whole leg? Do you go with the groin first and see how things go?
Okay.
What's your approach in prepping the patient for the procedure for a complex case like this?
We prep the entire leg. We try to do this in the hybrid suite, prep the entire leg in case we don't need to go retrograde.
Looks like we are back with Dr. Nouri. Did you open the AT?
Hello back. So what I did is I tried to cross the lesion, the anterior artery, but it is really very hard occlusion, and it wasn't possible to go intraluminally. And it is maybe possible to go subintimal and make a recanalization, but I think in this moment, in this situation, it would be good and enough to treat, and we treated now 3 stages: SFA, popliteal artery, and peroneal artery with a very nice collateralization. So my suggestion will be to wait for 4 or 6 weeks, and if we cannot achieve completely wound healing, so we will make a second intervention and try to open the anterior tibial artery from the antegrade and pedal access.
Right. Well, great. Thank you again for your work. It was a fantastic live case, and we appreciate you transmitting at this time.